Thank you for joining our community health and wellness discussion. This should be message number 4. We are going to be addressing an issue related to the current health crisis. What has happened is apparently there have been prevention and intervention efforts that have been based upon flawed global data. Currently, the United States population has essentially been blamed for either fueling or prolonging the current global health crisis. And this is based upon contrasting data. We were discussing this with respect to Africa recently, where the numbers are extremely low. They have been low consistently throughout the entire situation. You also have Asia with generally very low numbers. And so they are presented as either less impacted by the situation or in some instances more efficient in controlling. And this is used in order to create statistical analyses related to how different parts of the world might be doing. And so you've had in the United States these prevention and very hardline intervention efforts based upon these theories about the United States being more impacted and less efficient at controlling the situation. The question is, are these assertions and these assumptions accurate? And what has been found is that these assumptions and assertions are not only inaccurate, they are not well founded because there is no data to support this particular assertion. And so what we have are some community health problems going on that are related to meta-analyses problems. And so we're going to dig into this. Again, we're going to make this very succinct so you can follow along and you'll get the message. We have some main points and highlights for you to focus on in terms of creating that schema, in terms of understanding what is going on with this particular health and wellness dynamic. And just as a quick refresher about meta-analyses, what you have with the meta-analysis is basically a quantitative statistical analysis where they are pooling data from different studies. They are similar, but they are different. And they are looking for statistical significance. In order to have a solid meta-analysis, however, you have to have solid, valid, and reliable original data. So before you pull the data, you need to have good original data. And what we are seeing is that the original data is a bit questionable. And here we have this article that is offering 5 reasons why the current health crisis has been less deadly in Africa than anywhere else. And we're just going to quickly look at these 5 reasons that are asserted. The offerings are the assertion that 1, Africa took quick action. Number 2, they are purporting that there was an extreme amount of public support in Africa. Number 3, there was an assertion that the population is younger in Africa and there are fewer old age homes, and so therefore that was also contributing to the low numbers. They also offered that the climate, meaning the climate, the heat, the humidity, that was favorable to having low numbers. And then you also have number 5, they indicated that the numbers were low across Africa because of good community health systems. And then there is a listing in terms of information related to adherence to these health crisis measures and indicating that there was quick action with respect to hand washing, avoiding places of worship, reducing shopping trips, avoiding handshakes, avoiding public gatherings, wearing face coverings, and staying at home. Now, of course, these are the same measures that people around the world were basically given in terms of this particular situation. And you saw this, you saw significant adherence in America, in the Americas. You saw adherence across the world, in fact. And so, but these are the things that are being offered. There's no clear-cut research to support this offering or these 5 offerings, but this is out there. And what's happening is you have science being played out in public media, so in popular press, where it may not be based upon legitimate science, but the way it is presented, people are absorbing it and they are accepting it as legitimate science. And so again, there is no real science to support this. And what you see here is a contrasting view. You see the World Health Organization looking at the region for Africa, indicating that 6 in 7 of these situations go undetected in Africa. And so let's quickly go down the list of some of these data analysis difficulties. And so what has been found is that you have limited diagnostic criteria. There are many nomenclature problems. You have causation conflated with consequence or effect. You also have a limited amount of diagnostic data. It just doesn't exist. And then you have continental and national failure to diagnose people. So in some places, as you'll see, you have an overrepresentation. The United States would be that overrepresentation, where you have so many people seeking out diagnosis and being given diagnoses, even if they are not seeking out a diagnosis. And so you have an overrepresentation with some countries, and the United States is one of those countries, very specifically. And you also have a continental and national failure to provide data in some regions, some countries, some continents. And so you have some dynamics where you have a failure to diagnose and then a failure to provide data on any diagnoses. And so that is a problem, particularly when you're comparing and contrasting it with a country such as the United States, where there has been this extreme push to diagnose people, an extreme push to assess people. And so you have a dichotomy going on here in terms of the way that data is being collected. And so it's almost impossible to compare and contrast anything at this point with the United States or anything that's going on in America. You also have an overrepresentation of countries with respect to not doing certain things. And so therefore, what is going on is overlooked because it's not clear about what exactly is going on. And then finally, you have these prevention and interventions based on flawed global data. And so what's really odd is the diagnostic criteria. And so you have a health crisis that involves SARS-CoV-2 with this very limited diagnostic criteria. The only real diagnostic criteria appears to be assessment through testing. And so that's basically what you have. And you have a situation where, as with HIV, if you have a positive with respect to the testing, a person doesn't even have to have any symptoms. They don't have to have any signs whatsoever, and they will receive a diagnosis of a disease. But the problem is that the disease is not clearly defined. And so you don't have clear-cut diagnostic criteria, again, with that differential diagnosis, distinguishing SARS-CoV-2 symptoms from other things. And so you also have nomenclature problems where SARS-CoV-2 has been renamed in many instances the name of the disease. And so you will hear people say that they caught the disease versus they were infected with SARS-CoV-2. You will also hear about spreading the disease versus spreading the microbe. And so this is a problem. This nomenclature issue is a huge problem because you don't conflate the disease with the cause of the disease. You have to be very clear about that, and that clarity is not there. And so you have people doing research and talking and addressing these issues without clarity about exactly what it is they are actually addressing. And so people need to be very clear when they are talking about SARS-CoV. They need to say SARS-CoV. When they are talking about the disease, they need to be clear about the disease. They also need to be clear about diagnostic criteria. How was this determined? Again, so you have quite a bit of self-diagnosis, you have quite a bit of healthcare diagnosis without adequate signs or symptoms or consistent diagnostic criteria. Now, the World Health Organization has come up with these diagnostic criteria, and based upon that, you don't have the data from a number of countries in order to come up with the actual diagnoses. And so these numbers are off, and the data is just at a foundational level very flawed. And here you see this intricate dynamic going on here with this definition. And so you see that the disease itself has its own name. And then it says it's caused by SARS-CoV-2. It indicates that it was discovered in 2019 in China, that it's very contagious and has quickly spread around the world. Now, most people don't know how diagnoses come about, but there is a formulaic process for all diagnoses. And so with this, you have the World Health Organization actually presenting the diagnostic information for this particular disease state. And so you see this coming out of the ICD reporting guidelines. And this is from back in 2020. The guidelines have not really changed very much. So this is basically what you have. And so again, you see that word case coming up. And so you see a confirmed case is a person with a laboratory confirmation of infection. And this is irrespective of any clinical signs or symptoms. And so all a person has to do to be diagnosed is to test positive. And so in testing positive, those individuals are counted as a case. This has nothing to do with whether there are any signs or symptoms. And this is probably where the problem is coming up, because if a person doesn't have to have any clinical signs or symptoms and all you have is a test, when you push taking test and you push that on everyone and you push it over and over and over again, it's sort of over testing, you are going to have these extremely high numbers. And so these are not people who are necessarily going to the doctor with some symptoms and some complaints and then the doctor diagnosing them. These are people just randomly taking tests. I think there was one site at a gas station that was recently noted. And so people are just taking these tests all over the place, football fields, just anywhere. And so you have, and not for any medical reason. And so the people are not having signs and symptoms. And so technically, when you aren't having signs and symptoms, there would be no reason to be testing all of these people. That's not generally the way that laboratory diagnostic testing works. You're usually looking to diagnose a set of signs or symptoms. However, so you have all of this, what would be considered over testing going on in the United States, and you'll see that there is under testing perhaps going on in some other places. And so it looks like the numbers are higher in a certain place when that may not be the case. But if those are the numbers that you have and you push for those numbers, then you are going to have higher numbers. If you test, we'll use learning disabilities. If you test every child in the 3rd grade for learning disabilities, the numbers of learning disabilities that you are going to start finding when you start testing and doing a comprehensive assessment evaluation, you're going to find more people with learning disabilities. And so the more people you test for learning disabilities, the more learning disabilities you are going to find. It doesn't mean that there are more people with learning disabilities. It simply means that you found more learning disabilities based upon the process. The same thing could happen in this situation. So if you were testing everyone around the world the way that you tested the people in the United States, those numbers would go up. Does it mean that more people were positive? No, it simply means you found more people who happen to be positive. And so hopefully that makes perfect sense. And this is just enlarged so you can see it for yourself. Now from our list, we're going to look at the issue of the limited data. Now the statistical data comes from Our World in Data, and this is related to Oxford University. And so this is supposed to be the premier place to get your data related to the current health crisis. And so it even indicates that testing is our window in order to understand the crisis and also how it is spreading. And it says without testing, we have no way of understanding this situation. And so if you're not doing testing with everyone all around the world, then you really don't have an understanding of this current situation. And so you have people that are making decisions based upon what they saw on the evening news. And so you have here, it says, it is one of our most important tools to fight and slow down and reduce the spread of this particular situation. The testing allows them to figure out exactly who is impacted. And this testing actually guides medical treatment. And so here's the problem. If you're not testing all around the world, then you don't know exactly what you are doing in terms of whether your prevention is adequate or whether your intervention is adequate or whether you have even identified who requires intervention. And so we're going to quickly look at the data analysis difficulties related to overrepresentation and underrepresentation of discrete nations in data analysis, and how you need to start reformulating the way you are understanding the information that has been presented, because you again have these prevention and interventions based upon flawed global data, and you have these prevention and intervention efforts even in America based upon, again, this flawed global picture. And this is just to give you a sense of the import of this particular data. And so this again is related to University of Oxford, and you see the different entities that utilize this data. So you have Science, Nature, Proceedings, you have BBC, you have Royal Statistical Society, the New York Times, CNN, The Guardian, the Wall Street Journal, the Washington Post, CNBC, Vox. So you have quite a bit in terms of the media represented here in terms of who is using this data, who's depending on this data. And it also indicates that it's used in teaching at places such as Harvard, Stanford, Berkeley, and Cambridge. This data is also depended upon by major non-public organizations, governmental organizations, and so you have quite a bit of people depending on this particular data coming out of the University of Oxford. So let's look at this data. And you see here that this data is talking about the number of tests that have been taken by people across the world. And if you see, for some interesting reason, Denmark is extremely high there. And then you see the United States sort of leading the pack after that. And so you see this very high number coming out of the United States. And again, Denmark is extremely high there. You see this very high number coming out of the United States. Then you see New Zealand represented. But this is about the number of tests that have been performed. And again, it goes back to, if testing is the criteria and you are sort of modulating this testing dynamic according to country, you are going to have some different numbers, but it's not really going to be about the health crisis itself. It's going to be about the data collection. Now check out this heat map. When you look at this heat map, you should notice something. And you see at the bottom it has the scale. So you have no data, extremely light there. It looks like the color of the page. Then you get to 0, 20, 50, 100. It goes on, and you can see as the green gets darker, that's a part of the heat map, that's where the numbers are highest. And so if you look at this heat map, you can very clearly, it's a good visual, because what you see with this heat map is you see a number of places where there is absolutely no data. When you look at basically all of Africa, no data. That's with the exception of South Africa. So you see that large portion down there with South Africa. You see a little bit more data South and East Africa. Central Africa, really no data. And then that west coast of Africa, with the exception of one spot, no data. And so if there is no data, then how are you comparing and contrasting the experience of Africa and the experiences of other people around the world, in particular the United States. Then you go over to the right, and it appears that Russia has pretty much the same amount of data that has been presented as the United States. And so there's a high similarity there. You also see a similarity with Australia. So down below and over to the right hand side there. What is also noteworthy is you basically have no data coming out of China. You have no data coming out of a number of Asian countries, as you can see over there. And so this is a big issue. So if you are basing decisions on this data, there is a dearth of data. This data can't really be used for much of anything when you're talking about doing something cross-culturally, internationally. There's nothing you can really do with this data. You can, if you are an individual country, look at the data for your country and decide what you're going to do. But using this data to suggest that one country or one region or one continent is doing something in terms of prevention or intervention that another country or region might not be doing, that's going to be flawed. And so there have been all of these assertions about China in particular being so diligent in their prevention and intervention efforts. But how would you actually know that? Where is the actual data to support that? We come over to Africa, and there has been the assertion that Africa has not been as hard hit as was expected. How would you know that? And so if you don't actually have the data, those are not assertions that people should be making. Scientists should not be making those sorts of assertions. And here's another heat map. This one's coming from Johns Hopkins, but what's interesting is they are still using the Our World in data, so it's the same data. Now, when you look at this particular heat map, you see very similar circumstances with respect to these cases. You see the heat map looking very similar with respect to the United States and then parts of Europe. You again see this dearth of information coming out of Africa. You see these very low numbers. You also see basically no numbers, no data coming out of China, and that goes along with a number of places in Africa. So there is this Afro-Asiatic dynamic going on with this dearth of testing and this dearth of diagnosing people with this particular health situation. Now, when you have a diagnostic criteria, the one that we have that is so specific and related to the testing, you're not going to get beyond that when you start talking about confirmations. And so when you're talking about confirmations of cases, the confirmation is based upon the testing. And so if you don't have the data about the testing, you're not going to have adequate data in order to confirm these cases. And you look specifically here and you can see what looks like this trajectory for China. However, again, where's this data coming from? If you have a country that is not really diligent about reporting the data, or they are refusing to report the data, you don't have adequate data. And you see this odd illustration here where you see the numbers of confirmed deaths going up in March of 2020 and then just going right down and then just flat thereafter. This is not based on anything. This isn't based on any data. And so yeah, I have had individuals say, well, perhaps people should do what happened in China because they got everything under control and their numbers are down. Again, you cannot get your information about the science from the media, meaning the popular news programs. If you're going to be looking for data and making assertions about data, you have to get the data from legitimate sources. And so we don't have legitimate data coming from certain places in order to make assumptions or assertions about the data. And so you have this flat, surface there going across, indicating there are no confirmed deaths for this particular location. However, again, if they are not actually reporting the data, then you can't really have any credence in this particular data in terms of the assertions because you just don't have the data. And even these data collectors point out that you have to keep these things in mind with respect to the chart that we just looked at. You see that the actual death toll from the particular crisis is likely to be higher than the number of confirmed deaths. This is due, according to them, to limited testing and problems in the attribution of the cause of death. And so if you don't have people across the world using the same criteria to define these situations, then you can't do these comparative analyses. You can't do these contrasting analyses. You have to have things operationalized and you have to understand things the same way before you start comparing and contrasting data. And so what we have here are some regions that are not even reporting the data. And so therefore trying to make assumptions about prevention and intervention with respect to those regions, those things are going to be in error. And then to try to then compare and contrast these regions and these countries with countries that may be doing over testing and over diagnosing, you're going to have some erroneous conclusions that you're going to come to. And then that leads to some erroneous intervention attempts because you are basing all of it on flawed data. And so again, we have these data analysis difficulties. You have the limited data, dearth of data, you have continental and national failure to diagnose, and then you have continental and national failure to provide the data even if they have the data. And here you can see the data on the test per 1,000 people. And when you look at this again and you see the heat map's in green this time, you see that there are plenty of tests being administered in North America. It looks like plenty of tests being administered in Russia. Looks like plenty of tests being administered in Australia. And then in certain discrete regions where you see dark spaces on here, you see quite a bit of testing per 1,000 people. Okay, but when you look at a large portion of the world, you don't even have data for this large portion of the world. That includes Africa and large portions of Asia. And you can move India out of the large portions, and then you see some other discrete places. But when you look at the larger area, mainly China, you have some Indonesia, and then you look at all of these African countries, you see a dearth of testing or simply a dearth of data. And so you don't know what to assume or assert related to the testing because you just don't have the numbers. You don't have the data at all. Now here we put boxes around these regions so that you can see them sort of separated out from the whole, and you can see there are concentrations. And so you see these concentrations in, again, Africa and Asia, and then in a part of, looks like Central America, North America, you see this dearth in terms of data and testing. And then in the Americas, you see a dearth of testing and a dearth of data, basically. And this is just to make it a little bit more close up so that you can see this. And you can see that on this heat map, Brazil is relatively light there. You see Mexico being relatively light. And this gives you a better picture of Africa. And this also would account for why you have these higher numbers coming out of South Africa. If South Africa is the one that's doing the testing, then it's going to look like South Africa's numbers are higher. And what you basically have is South Africa reporting where other countries are not reporting. And here you can see Asia a little closer here. And so you can see that the entire area that makes up China is pretty much missing in terms of data in a way that is very similar to the large number of countries in Africa. You do, however, see these little discrete places with more heat in terms of this particular map. It's also noted that this overabundance of testing that appears to be going on appears to be related to certain demographics and certain people groups just around the world. And these people groups tend to sort of go together. Where you see one, there they all will be. And so you see the United States, you see India with a little bit more going on there. You see Australia in particular and South Africa. This is noteworthy because those groups of people are historically related in terms of the people that settled in those different places. And so when you look at these data gaps, you see that it is important to almost go back to the drawing board, because it's impossible to draw conclusions about the current crisis using the data that is available, the global data that is available, because this is extremely flawed global data. You have an entire continent that is not even providing data. You have a huge country not providing data. And then you have scientists and you have other individuals who have a voice coming up with all of these assertions related to why this may be the case in terms of these low numbers. And what should be pointed out is that you don't just have low numbers, you have a failure or refusal to either do the testing, you have a failure or refusal to diagnose consistent with what the World Health Organization is saying you should be doing. You also have a failure or refusal in terms of even providing the data if it has been collected. And so doing this comparing and contrasting dynamic with people around the globe, and then sort of finger pointing, indicating that some groups of people are doing it better than others based upon these numbers. This makes absolutely no sense. It's not based upon anything, and this is not what should be used in this situation. And also, there are questions about the process of the diagnoses of this repetitive testing, basically the same person in some instances. And so you have large numbers of tests that are being conducted, and so therefore you're going to have larger numbers of people with this particular diagnosis, because it doesn't require any medical diagnosis. It doesn't even require seeing a medical provider to get this diagnosis. The testing is the diagnosis, and so that is a huge problem. And so we've looked at these data analysis difficulties, and this means that when you are consuming data, you have people who create data, and then you have consumers of data. And so when you are consuming health data, you need to make sure that you have all of the information that you need at your disposal to make analyses about the data with respect to how you are going to conduct your life. And so as we wrap this up, it's important to remember that in order to have solid data, solid prevention, and solid intervention, you have to have solid, valid, and reliable data to start with.